Presently, we are looking at this question asking us about some marking for nucleus pulposus, embryological origin of that. And we can see it's a transverse section of the embryo showing 3 germ layers. Now, before we comment upon the answer, let us have some details of the diagram first. So, as we see, it is a transverse section of the embryo showing the 3 germ layers after gastrulation. The dorsal will be the ectoderm, in the middle we have the mesoderm, and ventral will be endoderm, which lines the yolk sac cavity lying on the ventral side, and at the floor of the amniotic cavity you can see the ectoderm. Now there is this axial mesoderm which we are talking about, the notochord, and notochord, the axial mesoderm, is going to form nucleus pulposus of intervertebral disc. Vertebra, they develop from paraaxial mesoderm forming the somite, which itself will form the sclerotome. Half vertebra will develop on one side, half on the other side, then they fuse in the midline to protect the spinal cord, which itself is part of central nervous system coming from the neural ectoderm. So neural ectoderm will form the central nervous system and the spinal cord, which is to be protected by some bone, and that bone is called vertebra. Half of vertebra develop on right side, half on left side by the paraaxial mesoderm or the somite or the sclerotome. Between the vertebra you have intervertebral disc and there is a nucleus pulposus. That nucleus pulposus is a remnant of the notochord, axial mesoderm. So that is our focus of interest here. And as we come back to our question, it was asking about the nucleus pulposus, and we know it is the notochord. So marker A should be our answer. Now when we say that our answer is marker A, what about the marker C? Marker C is the ectoderm, which is 2 type. If it is in the central area, it is neuroectoderm. If it is in the periphery, that will be surface ectoderm. And what about the marker B here? That is at the roof of the yolk sac cavity. That is the endoderm lining of the yolk sac cavity. And the marker D. Marker D is the mesoderm, which is various type: axial mesoderm, paraxial mesoderm, intermediate mesoderm, and lateral plate mesoderm. But here, as we focus upon our answer, it should remain choice number A, the notochord. As we can make out, this question is asking us about the heart primordium marking on this diagram, and let us zoom this diagram to have some idea about the developing embryo, which is in attitude of flexion. All the joints will be in folding. There is a cephalocaudal folding. The head comes near the tail during development. Now as we would notice that it is the head area, and then you have the upper limb, lower limb area, and this is the tail area. In between you are showing a marking which is for the heart primordium. We have a similar diagram here. Let us zoom this a little bit and discuss some of the details. What we can notice is this will be the frontal prominence, the developing embryo, and here you have the first pharyngeal arch, which is going to give 2 prominences, the maxillary prominence and the mandibular prominence here, the first pharyngeal arch. Then you will have a second pharyngeal arch, but between the two you will have a groove, or called as the cleft pharyngeal cleft one, which later forms the external ear canal as well. Then you have the second arch here and the third arch. Between the second and third arch you will have a cleft here, which is mentioned as the second pharyngeal cleft. The clefts are also called as groove. So this is the second pharyngeal cleft. Then you will notice the third pharyngeal arch, and some sinus is developing, cervical sinus. Actually only cleft number 1 will be persisting, otherwise cleft number 2, 3, 4 will be obliterated and later form cervical sinus, which later becomes cervical cyst and should disappear normally. The arches, as it is mentioned, will be forming the facial skeleton, like the mandible bone is also formed by the arches, arch number 1. The hyoid bone is developing in the arch number 2 and 3. Arch number 4 and 6 are involved in the formation of the larynx cartilage. Then we can come down to the heart primordium. So this was actually our question. They were asking about the heart primordium. You can also notice that there is an upper limb bud which is followed by the lower limb bud, and understand that they are appearing week number 4 and week number 5. By the end of week number 4, the upper limb bud will appear, and by the end of week number beginning of the week number 5, the lower limb bud will be appearing. And also evident are the somites which are developing on the dorsal side and later contributing to certain structures like vertebra developed from the somite, the sclerotome portion of the vertebra. Para-axial mesoderm on the side of the axis of the baby. So let us come back to our diagram now. And as we can make out, the marker A is the frontal eminence, which is basically helping us to develop the forehead area. Marker C is the first pharyngeal arch and the second pharyngeal arch area, which is basically developing the mandible and the hyoid bone. Marker D is the upper limb area where the upper limb bud will be appearing, and our answer should be marker B because it is the heart primordium. Here we have marked as such. And hence in this particular question, as you are talking about the heart primordium, our marker should be B and the answer should be choice number B as such. As we find, this question is asking us about aberrant subclavian artery. It is about the pharyngeal arteries as they develop in the 6 pharyngeal arches. There will be some contributions towards the carotid artery system, the subclavian artery and the arch of aorta plus the pulmonary arteries developing from arch number 3, 4 and 6. Now before you comment upon the abnormal subclavian artery, you should know what is a normal subclavian artery derived from, especially on the right side. So as I suggested, there are 6 pharyngeal arch arteries on either side. Arch number 1, 2 and 5 are going to disappear, leaving some vestigial remnant. Arches 3, 4, 6 are actually working for the adult derivatives, and arch number 3 will be contributing towards the common carotid artery, internal carotid artery system. That is not our focus of interest. Our focus is on the 4th arch artery on the right side, contributing to part of the right subclavian artery. As we understand, we are focusing upon right subclavian artery. It will have 3 contributions. One is the right-sided 4th arch artery. Next is the part of the right dorsal aorta. And third is the intersegmental artery number 7 on the right side. So 3 contributions are there for right subclavian artery, whereas the left subclavian artery directly come from the intersegmental artery number 7. Also notice that distal part of the right dorsal aorta should be normally obliterated, but sometimes it may happen that it is persisting, and that leads to some anomalies, like one of that is right-sided subclavian artery, which is aberrant in nature. Let us look at the details of persisting distal part of the right dorsal aorta then. So as we were suggesting that the right subclavian artery should be coming from the right-sided 4th arch artery and partly contributed by the right dorsal aorta proximally, and also partly contributed by intersegmental artery number 7 on the right side, whereas the distal dorsal aorta on the right side should be disappearing. Now here what happened is that the right subclavian artery is aberrant or abnormal, contributed by intersegmental artery number 7 as usual, but the proximal contributions have disappeared, which is the right-sided 4th arch artery and the proximal dorsal aorta on the right side. In fact, the distal dorsal aorta is persisting on the right side, and there are 2 contributions for this kind of subclavian artery. There is right dorsal aorta distally, which is persisting, and then there is right intersegmental artery number 7. Now this kind of abnormal subclavian artery is a problem, as it would be actually going around the visceral tube like the trachea and the esophagus. And if we are talking about this right-sided subclavian artery going dorsal to the trachea and esophagus can cause dysphagia illusoria or difficulty in swallowing as such. Aberrant right-sided subclavian artery. So as we come back to our question, why we have aberrant subclavian artery, it is understood that here part A gets disappearing and part B is persisting. That is, the distal part of the right dorsal aorta is persisting. As such, the fourth arch artery and the proximal part of the right dorsal aorta is obliterated, and this time the aberrant subclavian artery right-sided is coming from two contributions, that is the distal part of the right dorsal aorta and intersegmental artery number 7. Hence the answer should be the absent A and persisting B, or the answer is choice number C here. Here we got a question on the portal vein development, and we have to find out the marker. It is basically the front view of the developing veins, and where you can find three set of veins which are draining the body wall, the cardinal veins, the yolk sac which is Vitelline vein, and also the placenta which will be umbilical veins. Let us first have a look over the three type of the fetal veins here. What we need to understand is the body wall is drained by some cardinal veins. Like you will see, there is anterior cardinal vein which is further going to contribute towards the superior vena cava, especially on the right side of the midline. Then we also have the posterior cardinal vein which is contributing towards the inferior vena cava, and especially towards the right side of the midline. The superior vena cava and inferior vena cava are formed on the right side of midline, and as such the left veins should be regressing. They should be persisting only on the right side. When it comes to the placenta has two veins, the right and left umbilical veins, and it is understood that in fetal circulation the left umbilical vein will be persisting, whereas if you are talking about the right umbilical vein, it will be regressing in the fetal circulation as such. Then it comes to the yolk sac which is drained by the Vitelline vein, and the Vitelline vein you will find the right is more important as compared with the left Vitelline vein, because most of the left Vitelline vein will be disappearing, and it is the right Vitelline vein which is contributing towards the portal vein as such. You will also notice that this is the septum transversum which is later going to form the central tendon of the diaphragm, and is going to break up the Vitelline vein into certain components, but as such it is the right-sided Vitelline vein which is contributing to portal vein. Portal vein will have three components: minimal contribution from the left-sided Vitelline vein, significant contribution between the anastomosis between the two, and major contribution from the right-sided Vitelline vein. In the next diagram you can make out that. So once again you can notice that this is the yolk sac which will later form the gut tube, for example the duodenum, and drained by the Vitelline veins. This is the left and the right Vitelline vein. They will develop some anastomosis which are important, especially the middle dorsal anastomosis. Now what we find is that part of the right-sided Vitelline vein along with this anastomosis here is going to contribute towards the portal vein. It has three contributions: minimal contribution from the left Vitelline vein, significant contribution between the middle dorsal anastomosis, and the major contribution from the right-sided Vitelline vein. So this is the portal vein, three components which you can make again here itself: minimal contribution from the left Vitelline vein, significant contribution from the middle dorsal anastomosis, and major contribution from the right-sided Vitelline vein, the three components of the portal vein. Later the portal vein will give right and left branch, and you can see that in the fetal circulation the left umbilical vein will bring the oxygenated blood and is going to bypass the liver using the ductus venosus here, and then take the oxygenated blood directly into the inferior vena cava. So bypassing the liver is an essential requirement in the fetal circulation with the help of ductus venosus, but later the ductus venosus will be obliterated in the adult as the baby is born and become ligamentum venosum. Even the left umbilical vein will be obliterated to form ligamentum teres of the liver. And whatever we eat, the nutrients absorbed by the gut tube will be carried by portal vein towards the liver, right and left branches, and for metabolism, all the metabolites will be then collected by hepatic veins and drained into the inferior vena cava in adults circulation. So let us just remember the three components of the portal vein embryologically. Here you can mark them again. There was little contribution from the left vitelline vein, significant contribution middle dorsal anastomosis, and major contribution from the right-sided vitelline vein. So marker A should be our answer. When it comes to marker D, maybe on this side, B and D, they are actually the umbilical veins. So D is the left umbilical vein, which will be persisting in the adult circulation as the ligamentum teres of liver, and B is the right umbilical vein, which itself has regressed during the fetal circulation as such. Marker C is the left umbilical vein, which is most of it is disappearing. And when it comes to cardinal veins, this is the anterior posterior cardinal vein, and they contribute to superior vena cava, inferior vena cava, mostly on the right side, and the left-sided anterior cardinal vein, posterior cardinal vein should be regressing. It is the anterior cardinal vein which contribute to superior vena cava, and it is the posterior cardinal vein which contribute to inferior vena cava on the right side of the midline. And our answer should remain choice number A here. Marker A. At present, this is one of the histological slide asking us about the receptors seen in this particular region. This is a specimen for the skin epithelium, and this is the dermis superficial layer, which is papillary layer, and the deeper dermis will be still deeper. So it is basically giving us the dermo-epidermal junction, and that will be the superficial papillary layer of the dermis. We have to find out which receptor. If you say Merkel cell, actually Merkel cell will be in the epithelium basal layer of the epithelium, and when it comes to Meissner corpuscle, that could be our answer because it is at the dermo-epidermal junction in the superficial papillary layer of dermis. As it comes to Pacinian or Ruffini, they will be in the deep dermis, and that is deep reticular layer of dermis. Let us zoom this area a little bit now and find out the location of the Meissner corpuscle and also the various layers of the skin epithelium as such. So here is the Meissner corpuscle which we were talking about. It is at the dermo-epidermal junction, and it is in the superficial papillary layer of the dermis. That was our question. It is a rapidly adapting receptor for 2-point discrimination, tactile discrimination. And you can also see the various layers of the skin epithelium here. The most superficial is stratum corneum, which will have keratin fibers. Then there will be stratum lucidum if you have taken a specimen from thick skin like the palm or sole. Third layer, then you can have stratum granulosum, which will have some cells with the keratohyalin granules, which will contribute towards the keratin fibers of the first layer. And the layer number 4 is stratum spinosum, where you will have a lot of desmosomal attachment between the cells. Could be compromised in pemphigus vulgaris, which is autoantibodies destroying the desmosomes in stratum spinosum. And the layer number 5, which is stratum germinativum, where you have stem cells adding more and more layers towards the upper part of the skin. There you can also have the Merkel's corpuscle, which is for light touch sensation, like holding the pen, light touch sensation carried by Merkel cell in the 5th layer of the epidermis for light touch sensation. Let us look at the various type of receptors as well. The most superficial one would be the free nerve ending, which is actually coming into the epithelium to carry pain and temperature from the skin surface. In the social, you can also talk about the Merkel cell, which is a slowly erupting receptor for light touch sensation in the 5th layer of the epidermis. Then at the dermo-epidermal junction, you have the Meissner corpuscle, which is a rapidly erupting receptor for 2-point discrimination. If you come to the deeper dermis, then you'll have two of them. One is the Pacinian corpuscle to carry pressure and vibration. And in the deep dermis, you can also have the Ruffini receptor, which is to detect the dermal stretch as such. And there can be other type of receptors as well. But as such, the marker was here for the Meissner corpuscle, and let us come back to our question now. So receptors seen in the region, which is the arrow mark showing the superficial papillary layer of dermis or dermo-epidermal junction, the answer should be Meissner corpuscle, which is a rapidly adapting receptor for two-point discrimination. Merkel cell will be actually in the basal layer of the epidermis, the fifth layer, stratum germinativum, whereas the Pacinian corpuscle for pressure vibration, or maybe the Ruffini receptor for dermal stretch, will be in the deep reticular layer of dermis here. Understand that deep reticular layer of dermis is dense connective tissue, whereas in the social papillary layer you have loose areolar connective tissue. Less of fibers will be evident, whereas the deep reticular layer of dermis there will be more of fibers. And we keep our answer as choice number B here. And as we can see, this is asking about the type of connective tissue present in the arrow marked area. As we have marked already that there will be a superficial papillary layer of dermis and deep reticular layer of dermis. And deep reticular layer of dermis, you have more of fibers, so it is dense connective tissue, whereas the superficial papillary layer is loose areolar connective tissue. Now in the dense connective tissue also, the collagen fibers are not running parallel to each other, but they are running haphazard here in any direction. So it is dense connective tissue but irregular in nature. As such, the answer should be dense and irregular connective tissue. Now remember this dense irregular connective tissue which is seen in the arrow marked area. Deep reticular layer of dermis can also be seen in the periosteum perichondrium, around the cartilage, around the bone. When it comes to dense regular connective tissue, that could be in the ligaments or tendon and aponeurosis. If it comes to loose areolar connective tissue, then you will find that it will be seen in the superficial papillary layer of dermis, or it can also be seen in lamina propria. Both are subepithelial connective tissue, loose areolar connective tissue. But in this particular question, we'll keep our answer as deep dermis and dense but irregular connective tissue where the collagen fibers are not running in a regular fashion. This present question is asking us about this arrow marked structure here, and it is an electron microscopic picture. It is about the mitochondria, Golgi bodies, or maybe the rough endoplasmic reticulum or the secretory vesicles. Before we comment upon the answer, let us have a look over the secretions coming out of a cell into the lumen, where you will be involving the rough endoplasmic reticulum and secreting, giving it to the Golgi bodies, which will be packaging it and then sending it towards the lumen for exocytosis. So as we talk about that, there is a nucleus, and near that is you having the rough endoplasmic reticulum with the ribosomes involved in protein synthesis. There is some secretions which are being given towards the Golgi bodies, which is going to package it and put into secretory vesicles, which come towards the lumen and are getting merged with the plasma membrane, and then the secretions come out towards the lumen. So basically it was actually secretory vesicles which are coming from the Golgi bodies. Let us come back to our question again. So this was the marker. Actually it is the secretory vesicles which are given us by the Golgi bodies, and this is the rough endoplasmic reticulum which is concerned with the ribosomes and secretory granules. This is the nucleus here, which is also showing the nucleolus, and what you find here are the mitochondria, the powerhouse of the cell. You can see this is also mitochondria here, this is the mitochondria, and here is the lumen where you will find the secretory granules or secretory vesicles are getting merged with the plasma membrane, and the secretions move out into the lumen. So as we go back to our question, we can quickly make out that the marker was actually towards the secretory granules, which are going to fuse with the plasma membrane and give secretions into the lumen. So the answer should be choice number C, the secretory vesicles. And if you're talking about the mitochondria, this is the mitochondria, this is also the mitochondria here, and if you say Golgi bodies, they'll be near the secretory vesicles somewhere here, supranuclear in position. And when it comes to rough endoplasmic reticulum, you can see this is all rough endoplasmic reticulum, which is later with the ribosomes and concerned with the production of the secretion, which will be then packaged by the Golgi bodies into secretory vesicles. So our answer should remain choice number C here. As we find, the present question is asking about an organ which is having this kind of epithelium. It is multi-layered, so it appears like stratified. And you see the cells are having large nuclei, even the superficial cells are large and globular cells. Can it be urinary bladder? That's what we want to find out. It can be bile duct, because bile duct will be actually stratified, cuboidal, maybe 2 layers thick, but this appears to be 5 to 10 layer thick epithelium. It can't be gallbladder because it will be columnar epithelium with microvilli. Doesn't appear like that. It is multi-layered epithelium. Can it be skin? Because it is stratified in appearance. So let us have a brief idea about the various epithelia like skin, and then we can come back to the question again. Normally we should be able to identify the transitional epithelium, urothelium, which you can find in the urinary bladder, from the skin, which is stratified squamous epithelium, and from some columnar epithelium, which could be a simple columnar or it could be pseudo-stratified columnar. You see, if it is the urothelium, transition epithelium, it is multi-layered, can be 3 to 4 layer, and it can become 8 to 10 layer also. It is a stretchable epithelium, and if you have to store the urine, it can stretch, become 3-4 layer, and if you relax the urinary bladder, then it can be 5 to 10 layer cell epithelium. And the superficial cells are quite large, big globular cells that you will not find in the skin, because the superficial cells will be thin, flattened, squamous epithelium. So immediately you can make out that if there is a large globular cell, as you find here, and it could be even multinucleated umbrella shaped cells, it is transitional epithelium, and if it is thin flat nuclei, it will be a squamous epithelium as such. Though they appear similar, but one more thing you can notice is in the skin there will be papillary layer of dermis, so there are some wavy indentation of the epithelium here. It is going straight as such, no indentations are seen. Urothelium, urinary bladder, and stratified squamous epithelium in the skin. When it comes to columnar epithelium, you will have oval basal nuclei, and they are tall cells, and as you can make, there are some cilia seen here in the respiratory epithelium. It could be microvilli in case of gallbladder, but the epithelium will not be very thick as compared with the skin or the transitional epithelium or urothelium. Hence our answer should be the urinary bladder, because it is urothelium transitional epithelium. How do you know that? Because it is multiple layered cell. Even the topmost cells are large globular cells here, and they can be umbrella shaped cells, like I'll draw one here. These are large globular cells like this, and it could be 2 nucleated as well, like the umbrella shaped cells, the cells towards the lumen. And it cannot be actually skin, because skin, the superficial cells will have flat cell, and with the flat nuclei should be there, but we don't see flat cell, flat nucleus here, so it cannot be skin. It cannot be gallbladder, because gallbladder will not be multiple layered epithelium. It will be simple columnar with microvilli, and cannot be bile duct, because bile duct as such would be a cuboidal epithelium, which could be stratified cuboidal epithelium, but 2 layers at the max, and cannot be this much of layers. And moreover, that will be central spherical nucleus for the cuboidal epithelium, not the oval nuclei. As you can see here, there are columnar cells in presence of the chiral cells as well. So the only possible answer is transitional epithelium, which is the urinary bladder. We keep our answer as choice number A here. At present, it is electron micrograph and asking us for the label D, and as such we'll find out that it is two cells sitting together having some cell junction. So this is one of the cell we can make out, and there is another cell and having some cell junctions. The marker A as such represents the microvilli here, which can be moved by some microtubules sitting at the basal level, the basal body, marker E. So marker E is the centriole mechanism or the basal body moving the microvilli, which is surface projections, the marker A as such. But when it comes to B, C, D, you will find that these are some cell junctions. Towards the surface, you will have the B, where the intercellular space is very minimal, the tight junction. Here, this is the tight junction, and below that you come to the marker C, that will be the zona adherens. The intercellular gap is around 20 micrometer, and when it comes to the marker D, that is the desmosome level, it is +5, that is intercellular gap is 25 nanometer here. Let us have some more idea of this electron microscope showing the cell junctions between the two cells. Then, as you can make out, these are the microvilli which we were talking about, and the very first junction towards the surface is the tight junction. It is called tight because the intercellular gap will be very minimal between the cells. One cell here, intercellular gap is very minimal. So that can be seen here as well, the tight junction, and these were the microvilli we are talking about, the apical projections. Now when it comes to the zona adherens, you will find the intercellular gap between one cell and the other cell is 20 nanometer. So here you can make out this is the intercellular gap between the two cells and 20 nanometer. Then it will be increasing at the level of the desmosome, become +5, 25 nanometer, which you can also make out here. This is the level of the desmosomes. Desmosomes are identified by the fact that they have dense surroundings here on either side of the intercellular gap here, and it is below the zona adherens. This is also called macula adherens. The desmosomes are also called macula adherens. Now in this electron microscopic picture, you don't see the gap junction, but there will be gap junction which is still towards the basal level, and there will be some hexagonal structure, connexons, which is like a tunnel between the two cells. If you want to send some small molecules from one cell to the other, you can use the gap junctions. It can also allow the passage of some ions like sodium ion or calcium ion. And if it comes to the basal level, it is half desmosome, hemidesmosome, which is attaching cell to the basement membrane. These hemidesmosomes can be damaged in bullous pemphigoid, which will lead to the separation of epithelium from the basement membrane. Or if you say desmosomes can be involved in pemphigus vulgaris, where the cells separate from each other because autoantibodies against the desmosomes. As such, electron microscopic picture you can find towards the surface you have microvilli, and then you have the zona occludens or the tight junction, then you have the zona adherens, and then you have the macula adherens or called as desmosomes. So in this particular question, as it is asking about the marker D is none other than desmosome. Desmosomes, which are also called as the macula adherens, or they are also called as the spot welding. Marker C is just proximal to that, zona adherens. Marker B is still proximal or towards the surface, that is the tight junction or zona occludens. E is the basal body having some microtubule centriole system to move the A, which is microvilli, the apical projections there. We got one more similar question like that now. But here we'll keep our answer as choice number A, a spot welding or the desmosome or macula adherence. If you say choice number B, that is not evident in this diagram, will be the gap junction, which is between the two cells allowing free exchange of molecules. When it comes to C, it's the membrane, that will be the zona occludens or tight junction. And when it comes to move the microvilli, that will be a centriole system or basal body, marker E. But here at present, we'll keep our answer as choice number A there, the desmosomes, marker D. And we got one more question here asking for this marker, is the tight junction, zona occludens, macula adherens. You will find that this is the surface area towards which we will have microvilli. If it comes to this area, that is the tight junction, zona occludens. If it comes to this area, then it is the zona adherens, where you have 20 nanometer of intercellular gap between the two cells. And when it comes to this area, you have dense structure here on either side, that is the desmosome, 25 nanometer of intercellular gap between this cell and the other cell, the cell junction desmosome, which is also called as macular adherens or the spot welding. But as such, this is the marker, so we already have got our answer, zona adherens. Choice number B should remain our answer here. Now here we got a question asking that which of the following cell junctions are absent at this arrow mark, which is actually intercalated disc. There are some intercalated disc which are the cell junctions in case of cardiac muscle. How do you know it is cardiac muscle? You will see that it is the nucleus having a perinuclear halo. So the nucleus itself is having a perinuclear halo is a feature of cardiac muscle. Moreover, you see some striations, Z band, I band, A band, that could also be seen in skeletal muscle, but this is not a skeletal muscle because skeletal muscles, the nuclei will not have a perinuclear halo. So this is definitely a cardiac muscle showing some intercalated disc also, which is intercellular junctions, and they can have numerous type of cell junctions. That could be the gap junction for the transfer of the impulse, electrical impulse. Electrical synapses are there. Calcium ions can move from one cell to other through the gap junction. They also have desmosomes to hold the cells with each other in case of there is a contractility and stretchability, so the cells should not separate from each other. They also have zona adherens, but what they don't have is the zona occludens or the tight junction. So that should be our answer. They don't have any tight junction or zona occludens. They do have zona adherens. They do have macular adherens, which is the desmosomes holding the cells together, and they do also have gap junction for electrical synapse or sending calcium ion from one cell to the other for autorhythmicity and the rhythmic contraction. So the answer should remain zona occludens or tight junction there, missing from the cardiac muscles as such. Here we got a question asking us about a gland which is seen here giving some secretions, and it is seen that peripheral cells are intact, but the cells towards the duct are getting disintegrated, losing their architecture and then becoming the secretions. Now before we talk about the answer, let us have some detail of the various type of glands, which could be the merocrine, apocrine or holocrine type. We need to understand that glands like the parotid salivary gland will be merocrine variety, where only the secretions are coming out and there will be intact cell membrane. So cell membrane, there is no loss of cell membrane as such, and only secretions keep coming out. Merocrine or acrine variety, parotid salivary gland. Now when it comes to mammary gland, you will find that the apical portion of the cell is being broken and covering the secretion. So apocrine secretions can be seen in mammary gland, where apical portion of cell membrane is lost and covering the secretions come out as along with the secretion. When it comes to sebaceous gland in the skin, you will find that it is holocrine variety. Entire cell gets broken up and the cell organelles are also broken up. The nucleus, the cytoplasm, everything becomes the secretion, which is in this case called as the sebum. Histologically, you can make out if the cell membrane is intact and just the secretions keep coming out, then you will call it as merocrine or acrine variety, like the parotid salivary gland. But if there is apical portion of the cell membrane lost and becoming a bleb or vesicles covering the secretion, that could be apocrine, like in mammary gland. Or when you find the peripheral cells are intact but towards the secretory portion the cells are getting distorted and the cell organelles are lost and becoming secretion, like sebaceous gland near the hair follicle, you'll call it as holocrine variety of gland. So that was our question in fact. As I suggested, the peripheral cells are actually intact with cell membrane and organelles, but as you are going towards the duct, you will find that they are disintegrated and the secretions are actually merging up with the organelles coming out as sebum. So it is sebaceous gland and this is skin epithelium, and as such you will find that it is a holocrine variety of the gland. So answer should be choice number C here. If you say apocrine, that could be the mammary gland, where apical portion of the cells are being broken covering the secretion. If you say merocrine, then merocrine is the other name of acrine, where there is no loss of cell membrane. If you say endocrine, it is the secretion which is put into the blood with no ducts. But as such, sebaceous gland should be considered as holocrine. Choice number C should remain our answer here. Presently, this question is asking us about the type of structure which you will find this cartilage in the particular examples given here. Before we comment upon this type of cartilage or the example, let us have the three type of cartilages in detail. In hyaline cartilage, you will find that the matrix is hyalos, means there is absence of collagen fiber visible to our eyes in a light microscopic picture, and there are chondrocytes which are visible. But if it comes to the fibrocartilage, you will see there is fibers also which are evident. There is collagen fibers which are running along with the chondrocytes. And when it comes to the elastic cartilage, you will find there are some elastic fibers which are actually there. Short fibers, single running fibers and branching fibers. As compared with collagen, collagen is long length fibers, these are short length fibers. Collagen fibers run in bundles, they run singly, and here there is no branching of the fibers, but the elastic fibers are branching. So short, single and branching fibers, elastic cartilage with large chondrocytes here. So this is how you identify different type of cartilages from each other briefly. So here, as we can see, the fibers are not visible at the background. It is a hyalos matrix or absence of matrix showing any collagen fibers is hyaline cartilage. Hyaline cartilage as such, if you are searching for, then it will be present at various places, but the answer could be epiphyseal plate. The growth plate is our answer here. What about the intervertebral disc? Intervertebral disc will be actually having the fibrocartilage, and fibrocartilage is also present in the articular disc, like temporomandibular joint, articular disc, or sternoclavicular joint, articular disc. So these two examples would be actually fibrocartilage. As such, if you are talking about the pinna, maybe it is the pinna or eustachian tube or epiglottis. These three examples are for elastic cartilage. This is not elastic cartilage because we don't see elastic fiber. This is not fibrocartilage because we don't see collagen fibers. And the only possible answer is it is hyaline cartilage. So hyaline cartilage at the growth plate, or choice number C should remain our answer. Epiphyseal plate or growth plate. The present question is giving us some lymphoid tissue and asking whether it is tonsil or spleen, thymus or lymph node. Now here, as you can see, a lot of blue dots are there. They are all lymphocytes, actually making a lymphoid follicle also. This is the lymphoid follicle collection of the lymphocytes, and one typical feature which you find here is the presence of epithelium, which is stratified squamous epithelium. So this epithelium will immediately tell us that it is something in the oral cavity, like it could be palatine tonsil. This cannot be spleen, because spleen will not have this kind of epithelium. It will have the peritoneal epithelium, which is simple squamous epithelium, whereas this is stratified squamous epithelium. When it comes to lymph node or thymus, they don't have any such epithelium at all. Actually, they'll have some capsule as such, but not the epithelium. So this cannot be lymph node because it is not showing any epithelium as such, and the thymus, no epithelium. The spleen epithelium is different, which is simple squamous epithelium or mesothelium. So only possible answer is tonsil, because tonsil, palatine tonsil especially, will have stratified squamous epithelium with lymphoid follicle having a lot of lymphocytes. So only possible answer, choice number A, tonsil. The present question is asking which of the marked cell is giving hydrochloric acid. That will be the parietal cell, which is also called auxentic cell, and they have very particular appearance, typical appearance, which is seen here. These cells are some fried egg appearance, and that is parietal cell. So marker A should be our answer. Then what is this marker B or marker C or marker D here? Let us have some details now. First of all, we should know various type of cells seen in the stomach gastric gland. There will be surface mucous cells which are at the surface of the lumen of the stomach and giving some mucus, and then there will be mucous neck cells also. If it comes to parietal cell, which will give us the hydrochloric acid with intrinsic factor, they are pink cell, the cuboidal cells, and they are eosinophilic, taking more of pink stain. When it comes to the chief cell, they are towards the base of the gland along with the neuroendocrine cells, and there will be B or basophilic blue cells taking more of hematoxylin. They give us enzymes like pepsinogen enzyme. When it comes to the base or fundus of the gastric gland, not only chief cell is there, but also neuroendocrine cells are there, and they give us endocrine hormones like gastrin hormone. So blue cell, basophilic cell, hematoxylin cell is chief cell towards the base, and pink cell, the eosinophilic cell, parietal cell is cuboidal cell and slightly higher in the gastric gland. Now if we are towards the upper part of the gland, then we'll have these cells fried egg appearance, that is the parietal cells giving hydrochloric acid, intrinsic factor, and as you can see, they are having this fried egg appearance, pinkish in appearance. When it is towards the base of the gland, you have blue cells or the chief cells, basophilic, taking more of hematoxylin, and they will be appearing dark color, like this is chief cell giving some enzymes there. So identification of parietal cell, it is pink color, and the basophilic cell, the chief cell, is blue in color. Now when it comes to the slide which we had, it was actually taken from the gastric mucosa. You are magnifying it and further magnifying. Towards the lumen, you will find gastric pit. There will be some surface mucous cell, and then when you come to the upper half of the gland, you will have these parietal cells. Along with that, you can also have mucous neck cell. If you go towards the base of the gland, then you will have the blue cell, the chief cell, and there will be dark color as such. So as I zoom it, you will find that the question we had was having some markers. Towards the lumen, you will be having the surface mucous cells, and if you come toward the upper half of the gland, you will have parietal cells which are typical fried egg appearance, and along with that there will be some mucous neck cells. When you go towards the base, you will have the chief cells which are actually dark blue color because they take more of hematoxylin or the basophilic in nature. So as we can make out, the one which is secreting hydrochloric acid is parietal cell, and these are all the parietal cells. They have typical appearance. So marker A should be our answer. What is marker D? That is the chief cell. And what is marker B? That is the mucous neck cell. And what is the marker C? That is the surface mucous cells. Presently, we want to identify this anomaly, and it is observed that there is a small degenerated brain with a missing skull cap. So it qualifies as an anencephaly. But then we also notice that the skin is missing from the periphery, and it is not covering this defect area, where the vertebrae are also open, spina bifida, and there is open spinal cord and CSF leaking out, which qualifies as rachis-schisis. Rachis-schisis plus anencephaly, together you call it as the cranio-rachis-schisis. So that should be our answer here. As such, this question was asking us about the arrow marked structure, and immediately we can make out that it is the cerebellum here in the posterior cranial fossa, separated from the occipital lobe superiorly here, that be occipital lobe. Then you will have the cerebrum, actually the frontal lobe on the front side. You can also notice that one half of the cerebrum connect with the other half of cerebrum by some commissural fibers called as the corpus callosum here. So here you will have the splenium part of the corpus callosum. This is the trunk part of corpus callosum. This is a bend called genu, and then you can also have the rostrum of the corpus callosum. As we zoom a little bit more, you can notice here is the corpus callosum, and under that you have the fornix here, and you can also make out the diencephalon part of the brain. Here you will have the thalamus, and below that will be the hypothalamus. This is the optic chiasma. The optic nerve is the nerve of the diencephalon. Here is the brainstem, having three components of the brainstem, namely the midbrain here, and the pons here, and the medulla oblongata, which will then continue as the spinal cord inferiorly. So as such, the question was asking for the arrow mark, and that is nothing other than the cerebellum as such. And we can keep our answer as the choice number C, the cerebellum there. Presently, it is some image where we have to look at the marked structure, which is nothing other than the corpus callosum, and asking that which of the following it is going to connect. Here you will find this is the rostrum of the corpus callosum, this is the bend called genu, and then you have the trunk of the corpus callosum, and then you can also see the splenium. Splenium part of the corpus callosum is what they are marking, and splenium is connecting occipital lobe of one-sided brain, the right-sided brain with the left-sided brain. The fibers crossing commissural fibers will be found in the splenium part of the corpus callosum. So the answer should be striate cortex or the occipital visual cortex as such. When it comes to the orbital cortex, if you want to connect the orbital cortex with the other orbital cortex, corpus callosum fibers are there, but that will be in the rostrum part of the corpus callosum, that is connecting one orbital cortex with the other sided orbital cortex. So that will be the splenium part, which is for the striate cortex or the occipital visual cortex, and it is the rostrum part which is for orbital cortex. Then what about the dentate nucleus? Dentate nucleus is in the cerebellum, and it can be connecting with the thalamus, dentatothalamic tract. They will be using the superior cerebellar peduncle, and that you can see this is the cerebellum. It can use the superior cerebellar peduncle, which will be passing through the red nucleus and then go towards the thalamus, dentatorubro-thalamic tract. To pass the dentatorubro-thalamic tract, you will use the superior cerebellar peduncle. And what about the hippocampus? Hippocampus has one outgoing fiber, the major efferent tract, and that major efferent tract from the hippocampus is the fornix. So when it comes to the fornix, fornix is the major output tract for the hippocampus. But since the marker is here on the splenium part of corpus callosum, we'll keep our answer as occipital visual cortex, or the striate cortex should remain our answer, choice number A.